Good morning, everybody. Today's topic is understanding pain in abdomen in children, and this is another important practical topic which we need to understand because most of the kids come up with pain in abdomen, and we need to diagnose it, and we need to know how one should approach to a child who has got pain in abdomen. It is a very common complaint of a child that there is pain in abdomen. He cannot pinpoint it. He cannot exactly locate it, and the child, it is difficult in a child for a pediatrician to find out the site of the pain and find out the cause of the pain. Basically, we should know that there are three types of pain for any there are three types of pain which one can encounter. One is organic type, the second one is dysfunctional type, and the third one is the functional type of pain, which is also known as imitation pain or a psychogenic pain. So we need to know that we need to find out whether this pain is of organic origin or is of dysfunctional origin, or it is just a psychogenic pain which can be ignored of. A child might present with pain in abdomen in four different types of clinical presentations. One is acute severe pain. It is severe and it is of acute onset. The second one is a recurrent colicky pain. It comes up in episodes. The third one is a recurrent pain, again coming up in episode. The recurrent colicky was a acute type of pain which appeared in episodes, whereas acute severe is a single episode. The third one is a recurrent pain which again appears in episodes, and the fourth one is a persistent dull pain. Now, pain uh, is perceived by the body through the afferent nerves, which it is felt by the pain receptors. We have pain receptors in the body which get that perception, and which they pass on through the afferent nerves to the brain or to the central nervous system, where we can perceive it as pain. So these pain receptors are of types of different types, and they are located on the human body, on the organs, on the muscles, everywhere. So we have three types of pain receptors which are involved for perceiving the pain. One is the visceral pain or visceral pain receptors which are present on the viscera. The second one are the somatoparietal pain receptors which are located on the viscera and on the uh, parietal membrane. And the third one is a referred pain, where we don't have the pain receptors at a specific point, but at the point where the pain is felt, but an organ has been supplied by some specific nerve, and the same nerves supplies other part also, and therefore the pain from where the parietal viscera or the parietal or the somatoparietal receptors have received that pain, the same pain will be felt in other places where the same nerve intervenes, and therefore that is called as referred pain. If we talk about pain in abdomen, there are three pain areas with anatomical association. One is the epigastric region. In the abdomen, we have three quadrants in the epigastric region: the right and the left hypochondrium and the epigastric area. Then we have the periumbilical region. We have three quadrants in that too: the periumbilical area or the umbilical area, what we call it as, and the right and the left flanks, or someone might call it as the lumbar quadrants. And the lower abdomen, that is below the umbilical area, we have three quadrants over there too: the right and the left lower quadrant, and the hypogastrium or the infraumbilical area. So now, going into details, what is an acute abdominal pain? We have seen different types of pains: the acute, recurrent, colicky, recurrent, persistent, dull. So we are going to go about the details of each of the pain. What is an acute abdominal pain? Acute abdominal pain is generally a single episodic pain. You get that pain as a single episode and which lasts for a few hours, few minutes, or even a few days. But it is always a single episode. It won't recur. This lasts for few minutes to few hours to few days, and the intensity may vary over time. It might start as a mild pain and then become severely colicky, or it might become start as severe pain and then the intensity of the pain might reduce with time. So it is the intensity over of the pain or the severity of the pain changes with time. This acute pain is generally localized. You can exactly pinpoint the site of pain, and this pain has a specific character. If you ask the child who has got this pain, if you ask him what is the character of the pain, he will be able to tell you what the exactly pain feels like. This is described by the child as a sharp pain and or as a stabbing pain, like someone is stabbing him or someone is like trying to pierce him. That kind of pain he is very able to clearly craft it out, whether it is a sharp pain or a stabbing pain. Then we have recurrent pain. This is what we call it as recurrent colicky pain. A recurrent colicky pain may be called as a recurrent colicky pain. A pain may be called as a recurrent colicky pain if three or more episodes of the same character of pain occur over a period of 3 months. So we have to keep a watch on the child, and if the child gets the same character of pain, the same type of pain regularly over of about say three or more episodes in a short span of 3 months, then we are going to call it as recurrent colicky pain. Then it should be severe enough to cause interference in the routine. It should not be dull. The colic should be so severe that the child may not be able to perform his regular routine. It should interfere, the pain should interfere with the regular routine of the child. The pain comes up, and after some time, some hours or some days, the pain might subside, and again a new episode might come up. So in this way, in between these two pain episodes, there should be a pain-free interval. The pain-free interval will may be of variable time span. It might be of few days, it might be of few weeks, it might be even of a few months. So, but recurrent colicky pain, the same pain has to be within 3 months. So not more than 3 months interval is expected within these two episodes. So the pain-free interval should be of can be of variable duration, lasting from hours, days to weeks. And in this pain-free interval, the child will be totally normal, having a totally normal behavior. When the pain occurs or recurs, we would say, when the pain comes up again, the pain may vary in the intensity. The first episode might have a severe pain, but the second episode might have a slightly lower pain than the first episode, but still it will interfere with the daily activity, and might be the third one or the fourth one which comes up that might be more severe. So the severity of the pain will not be similar to that of the first episode or the previous episode or the preceding episode. Neither the severity will be like of the same severity will be maintained in the subsequent episode. So the severity may vary, the intensity might vary with each episode. Then we have something known as persistent dull pain. Dull pain is not at all very severe. It keeps on aching, but the child or the person who is having dull pain will be able to manage his daily routine with a small amount of hiccups within the his with his daily routine. So there will be some problem with his daily work, but still he can manage his daily routine. This persistent dull pain will typically last from days to weeks to months. It is a continuous type of pain. The persistent dull pain will be there without any, if not treated properly, it will be persisting over there. It will stay over there from days to weeks to months. But the interference in the daily routine will be minimal by the pain. The patient will be able to carry on his regular routine on his own. This will not be a typically pinpointed pain like in the acute abdominal pain. The pain will be diffused. It will be spread over a large area of the abdomen. There will be no single point of tenderness. The pain will be felt in most of the part of the abdomen, and so when you ask the child that where it is paining, rather than pointing it out with a finger, he would put a flat hand or the or the palm on the stomach, saying that the pain is over here. You cannot The child will not be able to make out the exact point of tenderness. He cannot localize it, and so it will be a poorly localized pain. The pain free intervals may be of variable duration. If there is a pain free interval, that might be of a variable duration lasting from months to weeks something, and again the intensity will be variable. The first episode and the second episode might give a different intensity of pain. Then what is visceral pain? As we have spoken of, that pain is perceived through pain receptors. So in case of visceral pain, the pain receptors are located on the serosa. Each uh, hollow organ, or I would say the intestine, has got four layers: the serosa, subserosa, the mucosa, and the serosa, muscularis mucosa, the submucosa, and the mucosa. In case of visceral pain that is related to the GI tract, the receptors are located on the serosal surface in the mesentery, within the intestinal muscle, and the mucosa of the hollow organs. So the site of the pain receptors are variable. They are present on the surface of the serosa, in the mesentery, in the intestinal muscle, that is the muscularis mucosa, and on the mucosa of the hollow organs. So they have a typical type of reception of um, a feeling. Even if there is a stretch, they will have get that reception. If even if there is contraction, they will have reception of that specific feeling. So that is a typical variation which can occur, and we can feel the pain with those visceral receptors. They respond to mechanical and chemical stimuli such as stretching, tension, and ischemia. Stretching and tension, these are mechanical, because of the intestine might get stretched, the hollow organ might get stretched, and that will give rise to some pain. Or there might be tension in that, and it might give rise to some pain. It might be fullness in that, and it might give rise to pain. And ischemia, or other chemicals which are generated, that might cause a corrosive action, that might bring up a pain feeling, and these chemical stimuli can also lead to pain. Generally, ischemia is the most common chemical induced pain. Visceral pain is usually dull, poorly localized, and perceived in the midline. The midline abdomen, you can perceive the visceral pain. So most of the time when your pain is in the midline of the abdomen, one should suspect it as a visceral pain when it is dull. When it is acute or when it is colicky, it is not generally a visceral pain. Then the another type site of presence of the pain receptors is the somatoparietal. That means the receptors are located on the parietal peritoneum, the muscle, and the skin. On all these parts, they have the pain receptors: the parietal peritoneum, the muscles, and the skin. The mucosa were present on the viscera of the organ, the visceral peritoneum, and the serosa mucosa muscularis mucosa, whereas in somatoparietal we have the pain receptors present on the parietal peritoneum, the muscle and the skin. They respond to pain resulting from inflammation, stretching or tearing of the parietal peritoneum. Initially for the viscera, they used to just respond to stretching or tension or chemical reactions, whereas the somatoparietal receptors, they respond to inflammatory markers, to inflammation, to stretching and tearing also of the parietal peritoneum. This somatoparietal pain is characterized by sharp, more intense and more localized sensation. You can specifically make out the site of the pain if it is a somatoparietal type of pain. It is very sharp as compared to the visceral pain which was dull, and it is more intense. The movement may aggravate the pain and thus the child will stay still. Any kind of movement the child makes, the pain will increase, and therefore the if a child we are seeing that which where you have the child is lying still, and if on movement the pain is increasing, then it is mostly of a somatoparietal origin. The child will keep his legs flexed so that the muscles are relaxed and the pain is subsided. Third type of pain was a sorry the fourth type of pain was the referred type. The referred type of pain is well localized. You can the child will exactly tell you that the pain is at this specific site, but the pain is not of that origin where it is arising. The pain is not felt in the area where the pain has arisen. This pain is felt in a distant area where the same cutaneous dermatome of the of the affected organ supplies the skin or the other organ. Like the liver is supplied by the same dermatome of the spinal cord, which again supplies to the muscles of the right shoulder. So pain in the liver or pain in the gallbladder will be felt in the right shoulder. So this pain at the right shoulder will be called as a referred pain. So in referred pain, though the pathology is well localized, though the pain is well localized, it is predominantly felt in the areas which are far away from the pathology, because they share a same nerve, same cutaneous dermatome with the pathognomic organ. This results from shared spinal cord level or afferent neuron from different sites. Certainly they have a same nerve which arises from the spinal cord, and they have a same afferent nerve, that is the pain receiving nerve, and therefore that specific pain will be a referred pain. Now we have seen that the pain in abdomen can be generally felt in the epigastrium, in the periumbilical area and in the hypogastrium. We have seen each of these areas have three quadrants. The epigastrium had right and the left hypochondrium and the epigastrium. The periumbilical area had the middle three quadrants, that is the periumbilical quadrant or the umbilical quadrant, what we call it as, and the two flanks or what we call it as the two lumbar areas, and we have three quadrants again in the hypogastrium, where we had the hypogastric area or the infraumbilical area, and the two right and the left lower quadrants of the abdomen, or what we call it as the iliac fossas. So pain emanating from foregut structures, when the pathology is related to the foregut organs like the esophagus or the stomach, this pain will be felt in the epigastric area, in the upper abdomen. If the pain is originating from the midgut structures, that is the lower stomach, the duodenum, the ileum, the jejunum, these are all the midgut structures, then it will be felt in the periumbilical area. And the pain which arises from the hindgut, that is the ascending colon, the transverse colon, the descending colon, then it will be felt in the lower abdomen. Now, the child has come up with pain in abdomen, and there are many practical difficulties which are faced by the pediatrician. The reason is the child will not, we need to evaluate pain on the history, and the child will not be able to give an exact history. The child may be limited in their ability to give the accurate history because they might not understand the question, they might not be able to give you the exact answer, they might not be knowing the exact answer, they might not be able to express the exact answer what they have in proper words. We might lag in the understanding of the child. There are so many things. Even the child might not be able to, though that is acute severe pain, the child might not be able to exactly pinpoint it because it is irritable. There are so many factors which can interfere with the practical with the history of the child. So we need, in most of the cases, we need someone who can interpret what the child says. But many a times, even the parents or the guardians who have come along with the child may not be able to interpret every complaint of the child, because they also might not be having that exact um, understanding of what the child wants to say because the child is irritable, or they might have difficulty in interpreting the complaints of the small child, or the parents might be so anxious, they might be too anxious to put up things in the in words. So therefore they also might not be able to give you a proper history or a proper interpretation of the questions answers what we need. So these are the practical difficulties, and therefore most of the time the job of the pediatrician in this becomes very difficult. Now when we want to evaluate the pain, the evaluation of the pain, we need to go systematically. We need to first collect the history of the child. Among the history, we need to know the symptom and the onset pattern of the pain, what kind of pain it is, and what when the pain started, and with what did the pain start. We need to know that. We need to know the progression of the pain, how the pain started and how has it come up till the present time. Means whether it started severely and it has come up, still becomes still severe till he has come to the doctor, or whether it has reduced or something like that. So we need to know the progression, even with the site also, whether it started in the upper epigastrium, it started in the epigastrium and went into the periumbilical area, something like that. We need to know the progression of the pain, how the pain has moved. We need to exactly know the site or the location of the pain. We should take a proper history. Should take a history about the intensity of the pain, whether it is severe, whether it is very severe, whether it is dull. All these things needs to come up with a questionnaire. We need to know the character of the pain, whether it is a stabbing pain, whether it is a radiating pain, whether it is a tearing pain, whether it is a dull pain, whether it is a stretching pain. We need to know. And these all characters are very difficult for a child to explain. We should take a history of precipitating and relieving factors of abdominal pain. This is possible when we have recurrent pain. A child when comes up with recurrent pain, we should be able to find out, or we should keep an eye to make it possible to find out what could be the relieving factors of the, and what could be the aggravating factors of the pain in abdomen. Then we should also look for associated symptoms with pain in abdomen, because pain in abdomen, though a common complaint or though a major complaint, it certainly gives rise to some other complaints also related to that organ. So we need to find out what are the associated symptoms of pain in abdomen, so that we can make out where the pathology must be located. We need to make exactly know the name, age of the child, because some pathologies occur only at a specific age. Like if the child is 6 or 7 years old, then in that case the chances of Meckel diverticulitis is much low. If a child is 15 or 16 years old and is sexually active, then pelvic inflammatory diseases or pregnancy related pain, they are common. If a child is too young, say it is preterm, then necrotizing enterocolitis might be very common. So or if the child is of 1 to 3 months, infantile colic would be very common. So we need to know the age of the child. We need to have an history of traumas and surgeries to the child. A direct or an indirect trauma, whether it was a blunt trauma or a sharp trauma, and whether the child has undergone any surgery. The histories are very important because in case of trauma, it depends on the intensity of the trauma, what organ might have been damaged and what might be the intensity of the pain. Whereas in surgeries, we need to know what organ had been dissected. We need to know the travel history because in cases of gastroenteritis or in case of infective hepatitis, there is most of the times history of travel from one area to the endemic area. We need to know the diet and stool pattern because low fiber diet is known to cause constipation and constipation causes abdominal pain. Similarly, spicy diet is going to cause dyspepsia and that can lead to abdominal pain. And we also need to know the comorbidities of the child. In history, we need to find out look at other points also. We need to take a detailed history also, the medication history. Some medicines like atropine can precipitate pain. So we need to know that whether the child is on some medication, whether there has been a, or in some diseases like uh, in some cases the drugs might precipitate pain when you take when you take sulfa drugs or when you take barbiturates and the child comes up with pain, then the child must be having porphyria. We must know the medication history also. Then we have a family history. We need to take a family history like in Crohn's disease or in ulcerative colitis or in uh, peptic ulcer disease. We can find out or we can make a diagnosis easily if we have a positive family history. We should take a sexual history, the age, the sexual activity of the child, or whether there has been a sexual abuse because pelvic inflammatory diseases or ruptured ovarian cysts or pregnancy related complications or ectopic pregnancy, they give you a specific history. Like in pelvic inflammatory diseases, you have a history of sexual abuse or you might be have a recent history of intercourse and that can lead to pelvic inflammatory disease. Or in case of ectopic pregnancy or in case of pregnancy complications, you might have a history of amenorrhea. So we need to have even the sexual history. And also we need to have a social and psychiatric history whether the child is psychologically fit and happy at home. Now these are the causes, general common causes which come up in which are related to pain in abdomen and they are according to the age. So in neonates and infants, we have infantile colic. Sorry, the pain in abdomen will be seen in neonates and infants in infantile colic, gastroenteritis, constipation, Hirschsprung's disease, incarcerated hernia, intersusception, volvulus, and urinary tract infection. In younger children, we will have pain in abdomen with gastroenteritis, appendicitis. Appendicitis is also common in neonates and infants. The other common thing in neonates and infants will be diverticulitis. In older children, we have again constipation, which is most of the time functional constipation. Then these younger children will have a functional pain or a psychogenic pain, more common. In diabetic ketoacidosis and urinary tract infection, we have got pain in abdomen. The trauma is common in these children. Pharyngitis and pneumonias will give rise to abdominal pain, though the pathology is in the thorax, henoch-Nolan purpura, and mesenteric lymphadenitis, they might give rise to pain in abdomen in younger children. In adolescents, we have other causes like appendicitis, gastroenteritis, constipation is very common. In girls, we will have dysmenorrhea, pelvic inflammatory diseases, ectopic pregnancy, ovarian or testicular torsion, which is again common in infants, then cholecystitis, IBD, that is the inflammatory bowel disease, pancreatitis, very rare. So these are the causes of pain in abdomen which are seen in adolescents. Adolescents would never give rise to pain, will never complain of pain with a functional or a psychogenic type. Yes, some female might give it with or might try to come up with psychogenic pain during or preceding the menstrual cycle, but that is sometimes happening. But functional, the typical pain of dysmenorrhea is present in adolescent age. So these are the diseases which are age specific and which present with pain in abdomen. We should know these so that we don't mix up with the diagnosis. Now going for evaluation of the pain, we had taken a proper history. What comes up with what are the causes? We try to find out in the history what could be the cause of the pain, the precipitating factor, the aggravating factor, the relieving factor, the history of diet, the history of food, the iatrogenic. We generally try to make it out. Then after history, we come for another point, that is the physical examination. In the physical examination, one should look at the general appearance of the child. Peritoneal irritation remains still. In case of peritoneal irritation, the child will remain still or it will resist movement because it has got more pain when the parietal peritoneum is involved. So it will try to restrict its movement because so that the pain can be relieved. So peritoneal irritation, in case of peritoneal irritation, the child will remain still or resist movement while the patient with visceral pain change their position frequently because sometimes in visceral where the visceral receptors are involved, the stretching might decrease with or the chemical irritation might decrease with change in position. So the child will be trying to find out a position where he will feel less pain. Whereas when the parietal or the somatoparietal are involved or when the peritoneum is involved, the child will remain still. The vital organs provide useful clues for diagnosis. When the child is associated with fever, then one can think that the pain has risen because of infection and a resulting inflammation. If the child has tachypnea, then that points out more towards pneumonitis. The pain in abdomen is because of pneumonitis. If there is tachycardia and if there is hypovolemia or hypotension and you get a positive history, the pain might be because of gastroenteritis. So we need to examine the child properly. Hypotension, yes, we can measure the blood pressure and look at the specific age related blood pressure, signs of dehydration, and we can make out whether there is hypovolemia and third volume space loss. If there is tachycardia, yes, we can say that this is because of gastroenteritis. On an abdominal examination, palpation of the abdomen moving towards the area of maximum tenderness should be done. You should start the palpating the abdomen from a far away point and slowly move towards the site of maximum tenderness. If you initially and foremostly palpate the site of maximum tenderness, there will be rebound guarding rebound tenderness, there will be guarding of the child and the child will not cooperate for examination, and therefore one should start palpating the abdomen from a point of least pain and slowly palpate towards the point of maximum intensity. We should determine the degree of abdominal tenderness, how tender the abdomen is. We should find out the location. We should find out whether there is rigidity and rebound tenderness, and we should even examine whether there is distension of the abdomen. Are there any palpable masses or organomegaly? Like in constipation, we might get, or in Hirschsprung disease, we might get piccolith palpable on the abdominal examination, or in case of intersusception, we might get a uh, hot dog sausage like palpable mass on the abdomen, or in case of hepatitis, or in case of hepatitis, we might get a palpable liver, or in case of splenomegaly with severe malaria or some other pathologies like the sickle cell disease, we might get even a splenomegaly. Rectal information examination provides useful information about the sphincter tone, presence of stool masses, and stool nature, even if there is hematochezia, that is painless passage of blood mixed with mucus, or whether there is melena. We should examine the genital area also, where we can make out, in boys, we can make out orchitis or torsion testis, which can be referred as pain in abdomen, or in females, we should see the genital area, because many a times with PID, you might get mucopurulent discharge from the cervix also. Even torsion ovaries, you have pain in the adnexal areas also. Most of the times, pediatricians overlook, or pediatricians need to know what are the alarming signs of pain in abdomen, and when the child needs to be treated, examined and treated on a urgent and emergency basis. We need to know what should be the signs, or what are the distress signs, or where the child should be admitted to a hospital. The first and foremost sign is the malignant pyrexia. That means temperature above 40 degrees centigrade or above 104 degrees Fahrenheit, and which does not respond to cold sponging or the routine antipyretic medicine. Despite giving antipyretic medicine and despite continuous cold sponging, or what we call it as tepid sponging, the temperature is not receding. That means this type of temperature is called, or this type of fever is called as malignant pyrexia. And we need to, if there is malignant pyrexia, the child should be treated on an emergency level at a hospital under proper medical care. If the child has rapid and thready pulse, which becomes indicative of impending shock, or which might become indicative, or which might tell us that yes, if the child is not treated, then he might land up into any kind of shock, the child should be considered, or this sign should be considered as an alarming sign. If there is severe tachypnea, the child, we have respiratory rates specific. In a neonate, it should be somewhere between 40 to 60. In younger children, up to the age of 3 years, it should be somewhere between 20 to 40, and in older children, it should be below 20. So if the respiratory rate is above 60 in neonates, above 40 in younger children, and above 25 in older children, that is considered as severe tachypnea. So if a child has severe tachypnea, if he has got air hunger, if we are finding out there is respiratory distress, he is using accessory muscles of respiration, still the child is air hungry, then that is considered to be a alarming sign. If the child is looking toxic, he is lustless, he is staring, he is having a staring look, he appears toxic, immediately transfer him to a proper medical care hospital. If the child is in hypotension, that is again a sign of shock, so he should be immediately admitted. If there is abdominal distension with increased or decreased peristalsis, then one should think of peritonitis, perforation, intersusception, volvulus, obstructions of the intestine, and this is a condition where one should not be treated on OPD basis. So the distance in these cases, the child should be admitted because that is an alarming sign. And if there is, if the abdomen is completely rigid and there is generalized guarding of the abdomen, one should admit the child. These are all alarming signs. So if any of these one or multiple signs are seen in a patient, never try to treat this child on an OPD basis. Now, once you have examined the child clinically, we need to go for investigation of that child. What should be the line of investigations? The first investigation line should be the blood investigation. We should ask the child to get a CBC. The parent should be asked to get a complete blood count, and that is recommended in all patients because that is useful in finding out whether the child has got an underlying infection and inflammation. So CBC should never be missed out or should never be left out in an investigation profile. If possible, get a complete chemistry panel. The chemistry panel will include blood urea, serum creatinine, blood sugar, and blood urea nitrogen. This is the complete chemistry panel. Also, you might ask for electrolytes levels also. Liver function tests are helpful baseline investigation when one considers that there is some hepatic or hepatobiliary or a pancreatic cause. The when there is get when you get a history of infected food, you have got other complaints, associated complaints of icterus, and you think that the liver is involved or the gallbladder is involved or the pancreas are involved, ask the child to get the ask the parents to get the child's liver function test done. Most commonly ALT, AST are required over here. Serum amylase and serum lipase is indicated if pancreatitis is suspected. If the child is saying of stabbing pain radiating to the back in the epigastric region, then it is most likely to be of pancreatitis. Though pancreatitis is very uncommon in children, in case of pancreatitis, if it is suspected, we should investigate for serum amylase and serum lipase along with blood sugars. Inflammatory markers do not really play any kind of role in investigations like CRP. It doesn't make any sense in asking the child to get an CRP done, but it might help sometime because they are just prognostic. The ESR also may not have any specific function or specific um, outcome, but it might be helpful if the child has got inflammation. It can be used as a prognostic marker, or it might be helpful in diagnosing or aiding the diagnosis of tuberculosis. In investigations of urine, after the urine investigations of blood, urine should be examined. Sorry, it should have been investigations of the urine and not blood urine. Investigations of the urine. Urine analysis is to be done to exclude underlying urinary tract infection or hematuria, which is associated with nephrolithiasis, that is the kidney stones, urinary tract infections, the hemolytic uremic syndrome, and the urinary tract or the kidney injuries. So urine routine is important where we can find out the amount of pus cells, that is the WBCs in the urine. We can go for whether the child has got RBCs in the urine. We can find out that thing. Even in chemistry, we can go for urine chemistry. We can go for leukocyte esterase in the urine and the nitrite test to be performed in the urine. A urine pregnancy test should be performed in children who are in the age group or who had menarche or are having regular menses and have a history of sexual abuse or a sexual activity. A urine pregnancy test or a beta HCG should be done to exclude miscarriage and ectopic pregnancies of females in reproductive age. Again, sorry, it has to be investigations of the stools and not the blood. Stool is the third part which is to be examined, third thing which needs to be examined after blood and after urine. The third common investigation should be of the stool. The stool microscopy and culture should be done. Culture does not really help most of the times because stool itself has got its own bacteria. But a culture would be helpful if we are suspecting of some infectious etiology. In a case of gastroenteritis, generally E. coli, that is Escherichia coli, if found in stool, is pathognomic. So in that cases, only stool culture is of useful nature. Otherwise, stool culture does not give any specific result. Stool microscopy, we are going to find pus cells, we might find bacteria. That is important. In 2017, the Infectious Disease Society of America guideline on infectious diarrhea recommends that when there is fever or bloody diarrhea, investigation for enteropathogens for which antimicrobial agents may confer clinical benefit should be done. And these microbes are Salmonella, Shigella, and Campylobacter. So if you are suspecting an infection with Shigella, a typhoid infection that is because of Salmonella or because of Campylobacter, one should go for stool culture. Otherwise, there is no point in doing a stool culture. And this should be done with all patients who have got blood in stools, all who have a bloody diarrhea. Other investigations, yes, we need to do. Those include sputum test for AFB if we are suspecting tuberculosis or we are suspecting pneumonia, sputum test should be done. If we have got pus in the flanks or somewhere else, a frank aspiration of pus and on thoracocentesis is diagnostic of hypemia, as empyema. And so when you have empyema, the pus should be examined. In suspected peptic ulcer disease, we should get the juices tested for Helicobacter pylori, and we should do a breath test or a stool antigen test for Helicobacter, which might be helpful in diagnosing that in organism. Serological markers like the perinuclear antineutrophil cytoplasmic antibody, that is PACA, and anti, uh, antisaccharomyces cerevisiae antibody, that is ACA, may be particularly useful for differentiating between Crohn's disease and ulcerative colitis in pediatric population. Crohn's disease and ulcerative colitis are not that common in pediatric population. If you get a positive history and findings similar to that of Crohn's disease or ulcerative colitis, only then we can go for PACA and ACA. Polymorphonuclear leukocytes, that is WBCs, that is neutrophils, seen on a wet mount of vaginal secretions, confirm vaginal infection. And this confirmation leads to the confirmation of a diagnosis of pelvic inflammatory disease. In all patients with pelvic inflammatory disease, it is important to screen for other sexually transmitted diseases like syphilis and gonorrhea and hepatitis B and HIV. So when you find that the child has got PID, the adolescent I would say has got PID, then we should also examine for HBV and HIV and HCV also without fail. And therefore HIV serology, syphilis serology, hepatitis study, and nucleic acid amplification testing or culture of vaginal secretion for Neisseria gonorrhoeae and Chlamydia trachomatis are indicated when you have a PID. So in other microscopy, the first thing which we should go, other than the stool and routine, we should go for sputum. Then we should go for vaginal secretions in case of females and other investigations also. In case we don't get anything in these or we have got some specific findings and we need to further investigate, we go for imaging, that is the radio imaging. It might be an x-ray of the abdomen, it might be a sonography of the abdomen, ultrasound of the abdomen, or it might be even a CT scan of the abdomen, or even it might be scopies. A plain supine and an upright plain abdominal X-ray are often non-specific. Supine, unless and until there is a perforation, you are not going to get anything in a standing abdomen X-ray, where in perforation you will have a gas under diaphragm. Or in case of obstruction of the intestine, you might have multiple fluid levels in the abdomen or in the intestine, where you can get a standing abdomen X-ray clear cut. Or if there is a radio opaque stain in the radio opaque stone in the ureter or in the kidney, you might get it in a plain abdomen X-ray. Otherwise, plain abdomen X-ray do not reveal any major specific pathology. An X-ray may suggest the presence of obstruction, fecal impaction, and duodenal atresia can be detected on an X-ray. It will show a picture of obstruction, that is multiple gas and fluid levels. In sufficiently radio opaque, it is maybe possible to identify gallstones or urinary stones on a plain abdomen film. When you give an injectable radio opaque dye, which is going to be excreted either through the gallbladder or through the kidney, you might be able to find out a stone obstructing the pathway of the bile or the urine. A free air under diaphragm suggests perforation, which we have already spoken of, and a chest X-ray should be ordered if perforation is suspected or a respiratory cause such as pneumonia or empyema is likely to be a cause of pain in abdomen. Ultrasound is a more reliable investigation as compared to X-ray and is recommended as nowadays as the first imaging test for most suspected intra-abdominal pathologies. Ultrasound scans are considered particularly useful in evaluating pain in specific quadrants. So if you inform the sonologist that the pain is in the right lower quadrant, he would investigate more in that area. If you inform the sonologist that the pain is in the right flank, he would investigate, or he would try to find out that specific cause of pain in that area. So that is the benefit of ultrasound, which helps more in abdominal investigations, more over the X-rays. A focused abdominal sonography for trauma, that is what we call it as FAST. The focused abdominal sonography for trauma, that is FAST, may be useful in children with blunt abdominal trauma who are hemodynamically unstable. A CT scan of the abdomen and pelvis with or without contrast may provide a high yield of information, but whether to expose the child to such a high degree of radiation is still debatable. If nothing conclusive is found on a sonography, only then one should advise a child a CT abdomen. And a CT abdomen can give you the perfect cause in the abdomen or in the pelvis when you use or you do not use even a contrast. It, a CT rarely misses out even a smallest of pathology. Now, why children should be kept away from CT scan? Because the CT scan gives a high amount of radiation, one. Secondly, the child might not be adequate. The child, while going to the CT chamber, he is quite irritable and he is quite anxious. So he might not respond, or he might not cooperate for imaging. So in those children, sedation or general anesthesia is required. Some children might not be fit for that. So if possible, one should prevent CT scan. But if required, you can do it under sedation or general anesthesia. Endoscopy, that is esophagoscopy, gastroscopy, duodenoscopy, or colonoscopy with a scopy with biopsy may be required to evaluate mucosa-based disease such as the peptic ulcer disease, the inflammatory bowel disease, the ulcerative colitis, all these things can be, or even a celiac disease, these can be diagnosed when you take a biopsy of the mucosa of the intestine, and that is possible when you go for an endoscopy, either an esophagoscopy, a gastroscopy, or a duodenoscopy, or a colonoscopy. Rectal biopsy and anorectal manometry help confirm the diagnosis of Hirschsprung's disease. In case of rectal biopsy, the mucosa will be the muscularis mucosa will be deficient of nerve intervention, which can be seen on histopathology examination, and therefore there will be a confirmation of diagnosis of Hirschsprung's disease. And on rectal manometry, you are not going to find out any fecal mass in the end rectum. So that will help in Hirschsprung's disease. Also, absence of fecal mass is a diagnostic of the large bowel obstruction. Nuclear medical medicine scans are also advised. HIDA scan, that is the hepatobiliary immunodiacetic acid. HIDA scan is done for biliary dyskinesia, where the intrahepatic biliary sinusoids are blocked. You can go for HIDA scan. Nowadays, people rarely do that. This HIDA scan is done generally in neonates with conjugated hyperbilirubinemia, persistent conjugated hyperbilirubinemia, which is of non-infective origin. And if this is there, nowadays people generally prefer a hepatic biopsy rather than a HIDA scan. But HIDA scan, that is a hepatobiliary immunodiacetic acid scan, is performed in biliary dyskinesia. Tectanium 99 scan is considered to diagnose a Meckel's diverticulum. Voiding cystourethrogram is indicated between the children of 2 to 24 months of age following an initial UTI if renal and bladder USG reveals hydronephrosis, that is, there is reflux vesiculitis, then, or you have seen scarring or other findings that would suggest high grade vesicoureteral reflux or obstructive uropathy. So if there is hydronephrosis, suspect that there is a vesicoureteric reflux because of some obstruction, and in those cases you can go for voiding cystourethrogram. Diagnostic laparoscopy may be necessary to confirm diagnosis of pelvic inflammatory disease, as it allows direct visualization of the gynecological and abdominal structures. So even invasive investigations like scopy or laparotomy, that is laparoscopy I would say, are advised, and even biopsies are advised. So if we go for an algorithmic approach in acute abdomen, we can see that if the abdominal pain is of less than 24 hours and it is associated with abdominal distension, specific tenderness, and peritoneal signs, and if the child presents with catastrophic presentation, he looks very sick, he has a severe continuous unstable pain and unstable vitals, then investigate on a plain abdomen film urgently, and we need to see whether it has a surgical intervention is required. We need to investigate on radiology, that is the abdominal ultrasound or a CT scan, and the most common diagnosis might be perforated perforations, then there might be intra-abdominal hemorrhages, NEC, that is necrotizing enterocolitis, then volvulus, mesenteric infections. If the child is very sick and there is suspicion of intestinal obstruction and you have bilious or feculent emesis, biliary vomiting, then perform a plain abdomen film of the X-ray. We require a surgical investigation, a surgical opinion, and there might be a volvulus in a neonate or intussusception in a child, or Hirschsprung disease in a child in case of if the child is between 2 months to 24 months, and if it is more than 24 months, or if it has got a history of tuberculosis, there might be adhesions. If there is suspicion of appendicitis, the pain will be localized and laparotomy might be required, but again investigation we need to require a sonography or abdominal CT. And in case of hepatobiliary disorders, we need to go for all blood chemistry, and from that we can be able to diagnose acute pancreatitis, acute cholecystitis, cholangitis, or choledocholithiasis. So this is when you need a surgical, or you find or you think that there is a surgical cause of pain in abdomen. So if there is you suspect a surgical cause for pain in abdomen rather than some other organic medical cause, then in that case your approach to a child should be in this fashion. It is totally based on a suspicion. Again, these are the causes of pain in abdomen. The gastrointestinal causes, we had seen the causes of pain in abdomen according to age. Now we are going to see it according to the systems. In what systemic diseases we can have pain in abdomen. The gastrointestinal system is the foremost system where pain in abdomen is incurred. The commonest are appendicitis, abdominal trauma, blunt or sharp, incarcerated hernia, intussusception, volvulus, Meckel's diverticulitis, necrotizing enterocolitis, intestinal perforation, IBD, gastroenteritis, peritonitis, constipations, peptic ulcers, and mesenteric lymphadenitis. These are the direct causes related to the GI tract. Then in peri-GI tract, that is the organs which are related to the GI tract, we have hepatobiliary and the splenic and the pancreatic organs. So the diseases, we have liver and gallbladder, we have the spleen and the pancreas. So the pathologies related to these can cause pain in abdomen. So those diseases are hepatitis, viral or non-viral, liver abscesses or splenic abscesses, splenic puncture, cholecystitis or cholelithiasis, cholelithiasis partial or completely blocking the bile duct CBD, splenic infarcts as in case of uh, sickle cell anemias, pancreatitis acute which is rare in children. Then the third one is genitourinary system, the urinary tract infection, nephrolithiasis, dysmenorrhea, PIDs, Mittelschmer's disease, ectopic pregnancy, and torsions of the ovaries or testes is common with genitourinary system, which can give rise to pain in abdomen. Cardiac causes give uh, are reflected with pain in abdomen, but they are not very much diagnosed with pain in abdomen. That might be a secondary or a mild symptom with pain in abdomen. There is the cardiac causes include myocarditis, pericarditis, endocarditis, or congestive heart failure. In case of congestive heart failure, you are going to have hepatomegaly, which can lead to pain in abdomen. There might again be biliary hypertension, that is the hepatobiliary hypertension. The pulmonary causes include lower lobe pneumonia, pneumothorax, and diaphragmatic pleurisy. The hematological causes include sickle cell anemia, acute leukemias, Henoch-Nolan purpuras, HUS, that is the hemolytic uremic syndrome, and all other diseases which are vasculo-occlusive, which block the path of the vessels and cause ischemia. Of this, common is sickle cell anemia or abnormal RBCs, which can block the like spherocytosis, ovalocytosis, astrocytosis. All these things can block the arteries, the capillaries, or the sinusoids of the liver and spleen and cause pain in abdomen. Metabolic disorders include acute porphyria. In case of porphyria, the pain in abdomen comes up when you take sulfa drugs or barbiturates. Then acute adrenal insufficiency, hypoglycemia, and diabetic ketoacidosis. We have some neurological disorders which are reflected in abdomen, that includes abdominal epilepsy and abdominal migraine, radiculitis or compression of the nerve root at the spinal level, or we have herpes zoster which can cause pain in abdomen because that specific nerve end is irritated and the same dermatome will give a pain at that organ also. Then toxins and drugs which can lead to pain in abdomen. Chronic use of these drugs can cause is lead poisoning is very common. Use of long-term use of erythromycin, as in case of if the patient is sensitive to penicillin and you need to give it in a case of uh, where the child cannot be given penicillin, then you need to give erythromycin for a longer term. So in that cases, then in salicylates, if you are using salicylates for a longer time, that is going to cause peptic diseases, and then you might require to give, the child might complain of pain in abdomen. Then venoms, that is scorpion bites or some other venoms can cause, or even other venoms of insect bites can cause pain in abdomen. Acute rheumatic fever, where you have to use long-term erythromycin if the child is sensitive to penicillin, is allergic to penicillin, can again give rise to pain in abdomen. And other infantile, other miscellaneous causes include infantile colic, pharyngitis, some functional or imitation or psychogenic pain, and angioneurotic edema, that is grade 1 anaphylaxis can cause pain in abdomen. So in short, this was about an approach to the pain in abdomen. When a child has got pain in abdomen, what should be your clinical approach, what should be one's diagnostic approach, what should be the line of investigation for these children. It has been explained in short in this presentation. Thank you.